Good afternoon, everyone. We're about to get started. We're just waiting for a few more to join, and then we'll go ahead and get started with today's event, our Menopause 201 webinar. Dr. Savage, for the sake of time, we can also just go ahead and get started if you'd like.
Sure, yeah, let's just do it. Because I know we're not going to have enough time to cover everything that comes up. I've already sort of committed us to more installments for sexual health. This is one of them. But I'm just so excited to be here. I'm Dr. Lisa Savage, and I'm with Geneve. Geneve is an online clinic for menopause management. We're a team of board certified OBGYNs. We have licensures across all 50 states. We integrate our care with a terrific team of RDNs or registered dietitian nutritionists to help with wraparound lifestyle care, nutrition, metabolism, and weight management. And part of our mission at Geneve is not only serving our patients, but also educating fellow clinicians. And this 201 series is for clinicians. And on that note, I am extremely excited about our guest today and our topic. Our guest is Dr. Lindsay Harper, a fellow Texan, and she has a downright inspirational resume. She got her MD from the University of Arkansas. Her residency was at the Baylor University system in Dallas, Texas. She then worked in private practice, which sparked an interest in women's sexual health because she saw that her patients needed a lot of information, resources, and help, and it was kind of hard to find. So she went all in, and she's now a fellow of ISWICH, the International Society for the Study of Women's Sexual Health. And in 2018, she founded Rosy Wellness. I want everybody to notice my rosy shirt. And Rosy Wellness has just taken off. It's a beautiful app that we doctors at Geneve recommend very frequently to our patients, and I would encourage all of you to do the same. And Dr. Harper, in addition to being the CEO and founder of Rosy Wellness, also works as a laborist in Dallas and serves as an assistant professor for the Texas A&M College of Medicine. So she's a very busy woman, and we are thrilled that she could take some time today to join us. And Lindsay, I just want to let you talk a little bit more about Rosy.
Yeah. Well, thank you so much, Lisa. I am a big fan of Geneve. I've actually known the Geneve team. I think we all kind of started around the same time. So I've known Becca for a very long time, and it's always so like heartwarming to be innovating in women's health alongside other physicians. That's something that has not been common in the past. So couldn't speak more highly about Geneve's approach, especially sort of as the menopause telehealth market gets a little noisier. So really excited to be here today. Thank you so much for that introduction, Lisa. Yeah, as you mentioned, Rosy is a digital health platform. So it's an app that women can download on their phones. And really, we started all about women's sexual health. Just as you mentioned, I was in practice and getting constant questions. I felt like once I started noticing it, I couldn't stop noticing it. And then it was like every single patient, and I wasn't even asking my patients about it. I was just doing what I thought was the normal checklist and not doing a good job of sexual health. And so then once I started asking, I mean, I was getting almost 100% hit rate. You know, like everyone had questions or concerns. And I was like, man, there's something really here. Why didn't I learn about this? Why did I spend 2 weeks at the VA and the erectile dysfunction clinic as a medical student, you know, like not even in residency, but as a medical student, but I had nothing like that on the women's sexual health side, like zero. And so that just left me feeling like not a great doctor, you know, because these women were coming, making these important disclosures. Like this is a big deal to share with someone. And then I felt like I was really dropping the ball in terms of what I was recommending or like how I was counseling. I just didn't know what I was doing. And so I started asking around, and I learned through a network of physicians that, you know, in fact, there is a medical society, which is ISWICH, dedicated to the study of women's sexual health. So I joined and became a fellow of that and really decided, you know, I would like to try to do something to make our jobs as clinicians and physicians easier, right? If we don't have something to do after we ask this question, I don't think we're going to be asking these questions very often. And so I felt like a next step would be really helpful. But I also came to realize that so many of the problems that women, or we can speak as women, but and women as our patients experience, are because of misinformation, embarrassment, shame, like all of this unnecessary, gunk on top of this actual sort of primary issue. And that gunk really weighs us down. That weighs us down in terms of progress, what we talk about as physicians, and what questions we ask as patients, and then what resources we're able to identify and access along that pathway. And so I really wanted to try to make a dent in that. Started Rosie with that mission, have grown the platform, are now recommended by 7,000 doctors and therapists, 12% of OBGYNs, but hopefully even more after today, and used by more than 250,000 women in the United States. So really excited about that progress, and so happy to be a part of the group of thousands of doctors and practitioners and healthcare providers at this point who are really pushing for change in women's health. And I know you guys are a big part of that as well. So anyway, it's my honor to be here. I love talking about this stuff.
Great. Well, I chuckled when you said, the VA ED clinic. It seems to be a national emergency if a man can't have an erection. But for women, it's understudied, it's undervalued, it's underfunded, and so we love talking about these things, educating clinicians so that they can take these resources back to their patients with confidence. And so on that note, the title of our webinar today is all about desire and the myth of desire. So we're going to get to that, but I want to start out talking about pain with sexual intercourse, because in my estimation, it's a full stop number one problem for women who report low sexual interest. And I'm always amazed at the patient who comes in and does share with me that she's worried about her sexual desire. And my first question always is, do you have pain or discomfort? And I'm always surprised at the percentage of women who say, oh my gosh, yes, oh, it's terrible. They don't necessarily present coming in, hey, doc, I have this pain. They say, hey, doc, my interest is low. So I think they don't necessarily correlate this pain with low interest. And it's because, everybody's concerned about, a woman being sexually interested. But the answer to that first question is so often, yes, it hurts, or I'm not that aroused. It's different than it used to be. So let's start out talking a little bit about how do we address that problem? What's been your experience with that?
Yeah, similar to you, it was really surprising whenever I sort of learned the architecture of like what types of sexual dysfunction exist for women, right? And how do we approach them? I think that is underpinning our lack of ability to talk about this in the way that we talk about every other, medical situation that comes to us from our patients, is that we don't even have the context or the framework from which to have these discussions. And so, sexual pain is actually the most common sexual complaint. 75% of women will have sexual pain at some point in their life. Oftentimes it's transient, say, postpartum, or, from some other incident such as that. But other times it's chronic. And obviously we know, we're all clinicians here, that it has many causes. The differential, for sexual pain is vast. But since this topic, is specific to menopause, I think that's probably a pertinent, piece of the puzzle here. And so we will suppose that perhaps this patient doesn't have a history of sexual pain, but maybe that's a new onset, for this particular patient, and that she's experiencing as a result of lack of estrogen or declining estrogen, vaginal dryness. And interestingly, what we've also found is those patients who are on very low dose birth control can experience the same symptoms. So that's another thing to kind of keep on your radar. Just when you're thinking about, lactation, we kind of also want to add like very low dose birth control to that list, as well as perimenopause and menopause. Because when that estrogen is lacking in the vagina, as we know, the architecture changes, as does, the lubrication properties, and that can really start to be uncomfortable. People describe it in many different ways, but I, like you, was trained that if someone comes in with a sexual complaint, whether it's desire, arousal, orgasm, anything, the very first thing we have to knock off at the top of the list is sexual pain, because as you know, and as everyone can infer, if we learn that we don't want, I have no desire to stick my hand in a fire because I learned that it hurts really badly. So if I know that penetrative intercourse hurts really badly, I will no longer have desire to do it, and I will no longer experience pleasure from it, orgasm, etc. And so that becomes the list of sexual problems. Sexual pain always rises to the top, and it really has to be addressed aggressively before we can get to the other layers. That's not to say that the other layers aren't real and don't exist and don't deserve to be addressed on their own. But until we address sexual pain, we can never expect people to have a regular or happy amount of desire to them. So definitely. And I think just like you, many of those patients are suffering from lack of estrogen that can be benefited from. Obviously, lube is for everyone. That's my other shirt. Besides Viva la Vulva, I should make a new one that says lube is for everyone, but lube is particularly for perimenopausal and menopausal people. But also, I think that the qualities and benefits of vaginal estrogen have been really, shouted from the rooftops recently, but that is really where it's at. And another product, I guess is the right word, pharmaceutical that I really love is vaginal DHEA, because as we know, it gets converted to estrogen and testosterone, and there are testosterone receptors in the vulva. And so they have also looked at the sexual endpoints with progesterone and found those to be just overall very positive when it comes to sexual outcomes. So I think there's addressing the primary problem, which is lack of estrogen, lack of testosterone, and then you can, augment along the way with moisturizers, lubricants, etc. What are your thoughts?
Well, I have a lot of thoughts along the same lines. And for everybody's knowledge, progesterone is intra-rosa. And one rate limiting step, it's a great product, but coverage can be minimal to non-existent for that product. So that's always a challenge. And gosh, I've always been so indignant about the out-of-pocket cost for just plain old vaginal estrogen. If you compare that to the cost of Viagra, which is a dime a dozen, it really is unfortunate that some of these therapies can be inaccessible for patients. But yes, shouting vaginal estrogen from the mountaintop is one of my clinical missions. And I always like to emphasize that it's safe for almost everyone, including breast cancer survivors, and it can and should be used indefinitely. So I think that, there's a lot of fear out there about estrogen in general and vaginal estrogen included, but we always emphasize to our patients that the amount of systemic absorption from vaginal estrogen is minuscule. It's not clinically significant. And the local effects are so profound, especially over time and maintenance. I always tell patients, we're going to do vaginal restoration. This is vaginal rehab. And I promise you, starting with the tissue integrity, everything else can follow. Even for the patients who do develop, say, vaginismus from chronic pain with intercourse, and ultimately will need pelvic floor PT, and we can talk some more about that. The physical therapist needs for those genital tissues to be in optimized condition for their therapies to then work. So it's always multimodal, but starting with making sure that the genital tissues can be aroused, can be receptive, can be elastic, it's absolutely critical. So there's pharmaceuticals. I also want to just make a mention of the non-hormonal remedies, which are fine. I always like to get to the root of the problem, which is estrogen deficiency in our population of perimenopause and menopause. But the ABOG, for anybody who's recertifying for ABOG, one of our maintenance of certification articles is on just that topic. So you could get some credit for reading it and kind of refresh your memory. But some of the over-the-counter products are nice. They're moisturizing. And I have a lot of my patients use both, maybe on an every other night basis. The nights that they're not using their hormonal product, they can use a moisture product if they even need it. A lot of times, once they're using a vaginal hormonal solution, they don't necessarily need the moisture products, but they're out there. And I'm just going to name names. I like the bona fide product called Reverie.
Yeah.
Replens is good. Those two categories, ingredients wise, are mentioned in that ABOG article. But we have to use a lot of different things in our toolbox when it comes to alleviating pain.
Absolutely. And I know maybe in the sexual medicine community, I don't know if you have the same opinion, but everybody loves Uber Lube for a lubricant.
Yes.
Yeah. I mean, so, and the good thing, and I'm glad to name names. I think this is the actual information that people need. You know
I
what I
know.
mean?
What
Rather
do I
than, yeah.
use? Yeah.
Yes. And the cool thing about Uberlube is as a physician, they will send you samples upon samples, or clinicians just generally, to your office. And then you can offer those to patients to use to try, because that's the biggest thing I think about lubricants is that it is not a one size fits all thing. Even though I have my favorite and you all have your favorites, like that doesn't mean that's going to necessarily be our patients' favorites. And so some companies. One of them was started by another gynecologist named Barb Dupree. Do you know Barb, Lisa?
I don't. No.
So she started a company called Middlesex MD.
Oh, yes.
And
Oh, I used to recommend Middlesex
yeah,
all the time.
yeah.
All the
So
time.
yes. So it's a website where, and the coolest thing that not the coolest, she's done a lot of cool things. One really cool thing that she has done is she's created like a packet of trial lube so that you can just order it and then try all these different ones. Because I think that, obviously everyone's different. But anyway, Uber Lube is great. It is silicone based. So you were not supposed to use it on sex toys because it can degrade the silicone. That being said, the newer versions of silicone sex toys are supposed to be able to stand up to that. And then, the other thing is it can stain sheets and things like that. So these are the types of things that people need to know. But it has great properties, and I think generally
Slide
is a
and
crowd
glide. I call it
favorite.
slide
Exactly.
and glide.
Yeah.
The thing about
Exactly.
silicone lubricants as opposed to water-based lubricants is that they will give you that slide and glide. They don't have to be reapplied at the same rate, because the water-based lubricants, they'll dry out, and they can even sort of extract water from tissues as they dry out. So we're always touting silicone, silicone, silicone. And we always recommend Uberlube. And of course, there are other good brands. We never have any commercial affiliations with the things that we recommend. But you're right about the sample program. It's brilliant, and they're very generous with it. They have a website, and it has other uses too. It has uses in sports medicine. They say you can use it in your hair for what that's worth. But I always say, just like you do, couples of every age need lube.
Yes,
And
absolutely.
there's this myth out there, especially among our male partners, that if a woman is not lubricating naturally, she's not that into him.
Right.
And I think that is something we really have to bust up, because I've seen patients, couples in my practice, where they have a real relationship impasse because of her inability to lubricate that's strictly physiologic. And so, yes, lubricants for all, absolutely.
Totally. And one more thing while we're on this topic, another product that I love is called O-Nut. Do you know about O-Nut,
I
Lisa?
don't, do tell.
Okay. So it's great. So it is, I always have heard that it's silicone. I'm friends with the founder. It's not actually silicone, but it feels kind of like silicone. I wish I had one. It is a ring that has, it's stackable, and it goes around the base of the penis for penetrative penis and vagina sex to prevent deep penetration. So for example, if someone's had a hysterectomy and they have a shortened vagina, or if they've had years of atrophy and their vagina is shortened from that and they cannot handle, deep penetration, then the O-nut can go around the base of the penis and act as a stopper basically for penetration, and both parties are much happier. The person with the vagina doesn't experience that deep penetrative pain, but the person with the penis feels full, like as if they're having full penetration. So it's another great product.
That is brilliant.
Yeah,
That's
it's
really
awesome.
brilliant,
I'll put
because
it in
so
the
many patients, yeah, do that. So many patients, if they have had sort of chronic atrophy that's not been addressed,
yeah.
they're going to need some type of gradual dilation. And we recommend self-dilation. We can talk about that. Of course, the pelvic floor PTs will use that as a tool a lot. But that sounds like a brilliant solution that takes into account the needs of both partners, which I do want to bring up that, this is a couple's issue. This is not just a woman's issue. And communication between a woman and her partner is so critical. One of my favorite books to recommend, as I'm sure it is yours, is Dr. Lori Mintz's A Tired Woman's Guide to Passionate Sex. And she talks about these kitchen table conversations. You don't necessarily want to bring all this up in the bedroom, but if you can have these honest, open conversations, and chances are, if you're shy about it or you're reticent, you're embarrassed, once you break the ice, that partner is going to be so relieved and so happy to talk about it. And I always use a Mr. Rogers saying, if it can be mentioned, it can be managed. And so I just wanted to kind of throw in there that this trouble with sexual pain or sexual desire, it's a couples issue. We don't just put all this on the woman because she usually has a partner, and we have to incorporate that relationship unit into our treatment plans.
Absolutely. And I think, Lori is also one of my good friends. She worked with us from the very beginning at Rosie because I read her book and was so inspired. She also has another amazing book called Becoming Clitorate. There it is. I love it. Yes. And so anything Lori writes, I feel like all of us should read. And actually, Lori does grand rounds on these topics. So like if anyone's interested, I can get that all connected. But she does it on obviously the like psychological side. She is a sex therapist. And I think to your point, Lisa, she gives us the language to start these conversations. And if we as clinicians and as physicians become educated on how to talk to our patients, then our patients are educated how to talk to their partners and how to make this a couple's sort of topic. And, one thing I always like to say is, I tell my patients and on the platform, we say, like, just tell your partner you were listening to this crazy gynecologist
Yes.
today and she said XYZ, and you can use that as a thought starter. You know what I mean? Like
Yes.
blame us. And you can tell that to your patients, like blame me. Like I just was, wanting to make sure everything was okay. And that way it sort of takes some of the pressure off. It allows for a little bit of humor. And it's a great place to sort of start, contemplating these ideas together rather than in the moment. And I think that's one of the contrasts that Lori's making in her book is like the last place you want to talk about a sexual problem is during sex or like after sex or before sex. It needs to be separated. Just like, you wouldn't wait until you're at the car dealership to discuss the budget for, the new car. You kind of set these plans together and try to take some of and sex just itself is so mired in all of these, difficult sometimes feelings because of the lack of conversation and education. And to your point, myths about, like lubrication and pain and desire and all of this stuff, it's quite complicated. So if we can bring some humor in, if we can create a safe space that's separate from actual sex itself, then many things can happen, right? You can say, or your patients can say, I really was into our sex life, when we were whatever, the first 10 years of our relationship. I kind of missed that. I want that back. Like, are you on board with figuring this out with me? Like, can we kind of be in partnership on this together? And sometimes it's just as simple as that. And most partners are really excited to kind of have that conversation.
They're thrilled.
Down that
They're
path.
thrilled.
Yeah.
Make it an invitation.
Yeah.
And you're right. If a patient can say, listen, I was reading this book or listened to this podcast or saw this webinar, this is what I learned. It's a really good segue into having that conversation. So I want to pivot. We said the word myth, and I think the word myth is in our title today, and it's all about desire. So let's talk about desire and the myths therein. We talked about addressing sexual pain, and I'm sure we could go on and on about that. There are other things to add into that, but I do want to focus us over on the desire piece because I think that for so many women, they feel abnormal about their own level of sexual desire. And I always emphasize, and I always say, if I could get on Oprah, maybe Lindsay, you could get on Oprah. You have innumerable, I should have mentioned, appearances, accolades, and honors. But if we could educate the female universe about the difference between spontaneous and receptive desire, we would alleviate so much worry, so much comparison, so much shame. We would normalize the most common female type of desire, especially after menopause, and that is receptive desire. Can you talk a little bit more about those two types and sort of the myths surrounding spontaneity?
Yes, absolutely. Well, I do want to mention some of our OBGYN colleagues were on the Drew Barrymore show recently. So we're making our way. We're making our way to Oprah. But yes, so I think, female reported low desire is the number one sexual complaint if you ask a woman at any given slice of time. So 38% of women report that they have low desire. And the question really becomes, what in the world does that mean, right? And I think that we as women don't necessarily know how to define low desire. And I certainly, as a physician, didn't know how to define it. And so when we talk about desire, when we start to learn about it, we understand that there are different types of desire. There's one called spontaneous desire, which is what many of us identify as normal desire, right? And this is because this is how desire is portrayed in the media. This is how many men, not all men, by the way, but many men experience desire, where I just kind of describe it as like you're just sitting around like typing an email and all of a sudden you feel, and
it descends upon you.
Yes, if you're like, yes, the alien comes down and whatever.
Oh.
But Lori, yes, Lori talks about it, and I don't because I'm a physician, but I love Lori so much, and she says, and you just get horny out of nowhere. She's the best. But basically, you just feel like having sex from seemingly nowhere. And ideally, that's a hormonal response or a neurotransmitter response. There's a lot that goes into it. And some people identify that way their entire life. Some people identify that way when they're younger, and then, or another key, in a new relationship.
Yes.
But then it kind of, dissipates or disappears or is fluctuating over time. That's also very common. And some people actually don't ever respond to that idea. They're like, that doesn't sound like me at all, right? And the important piece that's missing from this conversation is that spontaneous desire is only part of the conversation. There's another whole piece of the puzzle that's also very normal, particularly for women, called responsive desire. And what this means, let's talk about the spontaneous desire model for just one more second. The way this works is that your brain gets a neurotransmitter message that then goes down your spinal column to your genitals. So desire in your brain is followed by arousal in the genitals. Responsive desire is sort of opposite of that. And I'll use Lori's words again. It's not where you get horny to have sex, but it's in some ways, in some contexts, where you have sex to get horny. Okay. And so what this means is that first, what happens is you experience arousal in the genitals, and then that moves up to your brain and you experience desire in the brain. So it flops on its head, and that's totally fine. And like I said, for many women, that's how they experience it their entire lives. For some, it starts out spontaneous and then moves into responsive. And for others, it kind of goes in and out. And we can make these generalizations to men too. And I think the biggest takeaway is when we think about desire, to think about it holistically, not just meaning spontaneous desire, but meaning spontaneous and responsive desire, and with the knowledge that both are normal expressions of the same thing.
Exactly. I always like to normalize receptive desire. And I think I told you this, but I've had patients who wept in my office when I described receptive desire, because that has been their experience their entire life, and they didn't think it was normal. Women think that if they don't have spontaneous desire, I call it the cover of Cosmo type of desire, that they're somehow abnormal, and they never got the message, they never got the education about responsive desire, which I think is critically important to know the difference, to know that neither one is inferior to the other. But I have to emphasize to my perimenopausal and menopausal patients that responsive desire becomes a predominant type in our stage of life, and that spontaneous desire may be more frequent in ovulatory cycles, right? So it is, after all, a reproductive system. Mm-hmm. And Mother Nature's call to reproduce may come in as spontaneous desire in those ovulatory cycles. And once we're not having those anymore, we don't hear the call as much. And so the peri and postmenopausal woman may very well have had more spontaneous desire now than she does now, and she thinks that that's a problem and that's abnormal. Right. So if we can educate her more on embracing responsive desire, normalizing it, sharing it with her partner, allowing for arousal. And I always tell patients the takeaway is this: with responsive desire, desire comes after arousal, as you said. And then I say desire may not lead you into the bedroom, but it can very well follow you there if you let it, if you change your mindset and expectations around, what's supposed to happen.
Right. Absolutely. And, I've learned so much from Lori, so I'm just going to keep bringing her up this whole time. But one thing she says is that, really desire and sex is never spontaneous in most situations. She's like, when you were first going out on a date with your now long-term partner or whatever, if you think of your last long-term relationship, she was like, you knew you were going to get ready for that date. You shaved your legs and you primped and you kind of thought about what was going to happen later that night. And she's like, so your brain was setting the stage for what was going to happen. It wasn't just an all of the sudden type experience. And so, I think there's a lot of different ways to kind of think about that. And another thing is that, responsive desire actually responds to a lot of different things, right? So you could experience desire in response to actually having sex, or starting to touch and kiss and become intimate with yourself or your partner. But you could also experience it in reaction to erotica. And Lori actually did the first sort of published work when it comes to that, and then Rosie has taken and extended that work, which is to show that erotica as a tool to kick off responsive desire is really powerful. And when you think about this and explain it to patients, I always talk about erotica as a prescription, not to medicalize it, but to say, hey, this is way cheaper, safer, like more approachable than any pill I can offer you.
No side effects.
No side effects. Yeah. It's just, it's a little story. Do you know what I mean? And then it helps you to accomplish the goals that you have with your partner. And most women, as we're talking about, will have, maybe they'll have spontaneous desire and you'll never have this conversation with them. Most women who come in will have a response to this responsive desire sort of framework. And then there are a smaller amount, which I know we'll get to, that do potentially qualify for a diagnosis. And for those women, they'll say, I don't care what I read or what I watch or the dream partner that you send to me or all the stressors that you take away from me, it is not happening. And that's sort of another subset that we can also talk about as well.
I think that's an important distinction because I think a lot of women think that they have a diagnosis, HSDD, hypoactive sexual desire disorder, because they are comparing themselves to somebody else or their partner's level of desire. And it's not relative to somebody else or relative to your partner's natural desire cycle or level. It's more relative to yourself and what you used to have in terms of your sexual desire. But let's talk about that diagnosis in terms of what is it exactly, who experiences it, and then we can talk about some of the treatment modalities for someone who actually does have that diagnosis.
Yeah, for sure. So HSDD, there's some complexity in how this is talked about because more recently it's been referred to as FSIAD, but we're going to stick with HSDD because that's how the medicines that treat it were labeled. So as you mentioned, that stands for hypoactive sexual desire disorder. And what it means is for greater than 6 months. So this isn't just like a few weeks thing or a situational thing where you're like, man, I'm mad at my partner and we're not doing this, or it has to be a prolonged thing. It has to be a generalized thing. So this is another key point where it's not just one partner, your partner, that you don't want to have sex with, because some people are kind of over their partner for whatever reason, and then they may have interest in this other person or this this other sort of idea, and so that also is not qualified. So you have a significant lack of or no interest in sort of participating or initiating in sexual activity, and also no responsive desire, just like we talked about. So basically, when they look at functional MRI of women with HSDD, and these people are exposed to erotic video, the people without HSDD, you can see the parts of their brains, their neurotransmitters firing, and then people with HSDD, not so much. So the way that I've come to kind of think about this is akin to depression, right? It's like the things we used to find joy and happiness in, we are not able to do so no matter how hard we try or no matter how bad we want it. And that's really where the rubber meets the road. These women are really people are trying to access that prior, sexual identity and that bond potentially with their partner, and they're just not able to do it, not spontaneously, not responsively, and it's causing some distress in their life as a result of that.
I think that's such an important distinction to make. I'm so fascinated with the functional MRI studies because it really just gives sort of the scientific explanation and the validation of some people's experience with HSDD. So let's talk about some of the pharmaceutical treatments
Yeah.
and other modalities as well. Are there other things, or is HSDD always something that needs a prescription?
Well, that is a controversial topic, and we have not published this, but we have studied, Rosie, on women who qualify for a diagnosis of HSDD based on the decreased sexual desire screener, which is the like standardized clinical questionnaire, and we were able to show statistically significant difference with just Rosie as an intervention. So I just want to qualify that. So my point of including that little tidbit is to say that everyone needs behavioral interventions, no matter what. No matter if you have HSDD or you don't, you need to learn that 86% of women have orgasms through clitoral stimulation. You need to learn that lube is for everyone. You need to learn that, how to talk to your partner about sex. Like, these are foundational elements that all of us are missing because of the way that the world talks about and doesn't talk about women's sexuality and sexual health. So that there is therapeutic value in that for everyone. Now, for women with HSDD, because there is this change, this difference in the neurotransmitter sort of pathway, most women, and I think, deserve access to some pharmacological option who are in that category. And so there are 2 FDA approved options for women who have a diagnosis of HSDD. And then there's one, that I know we'll get to that we use more off label. But the 2 that are available for women approved by the FDA are approved for premenopausal women. Now, that didn't do us any good. Unfortunately, that I think that most of us feel as if that was an unnecessary sort of marker from the FDA, but that's who the studies were done and guided by the FDA. But as we've just discussed, this is happening in the brain. That's like saying, oh, premenopausal women can have Celexa. It's like, what? That doesn't make any sense physiologically. This is the same sort of response. There's not a hormonal component. We don't have to worry about that. But anyway, it's FDA approved for premenopausal women. Many sex medicine doctors will use it past that age. The 2 FDA approved options. The first is flibanserin, or Addyi, and that is a nightly oral medication. Originally, when it came out, there was an alcohol contraindication. Now the label has been changed to, if you drink alcohol, you should not take your medicine that night, which is, fine for most women. And then the biggest side effect is sleepiness. So you don't take this medicine to get ready for sex. You take this medicine before you go to sleep. So you may have already had sex or not had sex or whatever, but it's basically what you do right before you fall asleep, not to get ready for sex. It's best to give patients an 8-week trial on the medication, and there's about a 50% response rate. So 50% of women are going to say, yeah, I think this could be helping. Like, let's keep going with this. And then another half of women are going to be like, meh, I haven't noticed a thing. Like, this isn't it for me. And so that is the first FDA approved medication. The second one that was approved a few years later is called bremelanotide, or Vyleesi. And it is a subcutaneous injectable that you take about 45 minutes before you want to be sexually active on a PRN basis, obviously. So you're not supposed to take more than 2 doses in a week or more than 8 doses in a month. And it has around the same efficacy. So between 50 to 60% of women will be responders, and we give them an 8-week trial on that medication as well. So, I think there's a lot to unpack here when it comes to medications for HSDD. For me, from where I stand, I want, just like in contraception or just like in, menopause hormone therapy, I want patients to have options, because there's never going to be one right therapy for anyone in any, situation. And so the more we can have these conversations, the more options that we have. If we don't like one, or one doesn't work, then we have another one to switch to. If our insurance doesn't cover this one, then maybe they'll cover this one. There's a lot of different reasons that more choice is better. And so that's really where I stand, is I want more tools in the toolbox for women, and I want women to have the agency and the information to decide which option's right for them.
Totally agree. And, just to add about off-label dosing, we use a lot of things off-label on a regular basis. So, and for example, the Addyi, it's a serotonergic antidepressant, basically. And so who says that women past a certain age can't take those? Nobody says that, just like your example about Celexa. So that the restriction, I don't even want to call it a restriction, it's more just a indication, doesn't make a lot of physiologic sense, actually.
No.
And just one more word about the injectable that I did not know until I went to the Menopause Society meeting is that, yes, it's a PRN basis and to be taken 45 minutes before you expect something might happen. But then there's a 16-hour window during which it's still helpful. And I didn't know that. I thought it was sort of just like short-term effectiveness. But I guess, over the next 16 hours, you might still have some benefit from that.
Yeah, and I mentioned the sleepiness with Addie, so I need to mention the nausea with Vyleesi.
Yes.
And so nausea is the number one side effect with Vyleesi, experienced in about 40% of women. But the more they take it, the less they experience of it. And so oftentimes, if I'm writing a new prescription, then I'll co-prescribe with some Zofran and just say, hey, like, let's just head this off at the pass. If you don't notice anything, you don't have to take it again, but you'll have it if you need it. And that can be addressed. Because, we want women to feel as prepared as possible on this stuff. If they get something home and they're nauseated from it, they're not going to take it again.
It's not sexy. Yeah, that doesn't put you in the mood to be nauseated.
Not sexy. Yeah, but it goes away. It goes away.
Okay.
So, yeah.
Well, you know what? Prescribing most medications is trading one problem for another. But if we can manage the side effects and also educate patients about what to expect, I think that makes a huge difference. But I just want to talk about ROI a little bit with these two medications. I'm a bit of a skeptic. I've never been so impressed, and I love having things in the toolbox. But success was defined as having 1.5 additional satisfying sexual encounters per month. Not per week, but per month.
Yeah.
And so again, expectations, you don't want to tell your patient, oh yeah, you're going to be randy and, you're going to be, having those feelings and you'll have so many more satisfying sexual encounters. The impact is modest. The success, the bar for success is not super high. But it's all in the eye of the beholder. It's all in that one individual patient's experience. And placebo effect is effective too. Let's not forget that. And so whatever effect it is, if it's positive in her experience, then it's positive.
Absolutely. And I like to think about it like this. If a patient is going from one episode of quote unquote duty sex, where she is having sex because she feels like she has to and she could not care less, and it's just, it's a chore to tick off the list. If she can transform that one sexual event a month to a mutually fulfilling, exciting, you can read that, your partner can read that, like, that is a world of difference. Do you know what I'm saying?
That is such a great perspective. Context. Yeah. It's context.
It is. It doesn't even matter if sex is happening more or less regularly. It is, what does that mean? And you just made this point, but what does that mean to me as the person, as the woman who is, struggling for something to, and so I do think it's worth a shot in women who qualify, and then we can let them tell us sort of what that experience means.
Exactly. I think that's such a good perspective too for relationships, because our partners want us to be excited. They do not want us to just have it be a chore. Nothing makes them happier than for a woman to authentically be into her partner, be into the experience, be fulfilled by it. And so, again, going back to the partnership, the couples situation with sexual encounters or your sex life in general. All right, so you alluded to it. We're going to get on the T train now. Testosterone.
Yeah, I mean, testosterone, I feel like, is the one everyone wants to talk about, wants to take, there's so many benefits to testosterone for women. I was going to just share this really quickly because Becca, who is, with Genev, I have, this is my like ACOG talk from not this year, but the year before, I think I can share, wrote an article on exactly this topic. And I just want to make sure that everybody here has access to read it. Yes. Okay.
Green Journal.
There we go. Green Journal. It is from November of 2021. And it is, I think, the best current overview of sort of how most of us in menopause, in sexual medicine, think about testosterone. And so if you haven't read this, this is 100% the place to start. And I also like it because they give very practical advice on monitoring. And I mean, it's just exactly what you want in a textbook, to be honest. So if you haven't read this, then please do yourself a favor and read it. Let me just stop that. Okay, so I think, the takeaway from testosterone, particularly when it comes to sex, is that it has beneficial results on every aspect of sexual function, on desire, arousal, lubrication, and orgasm for women. And there's just no getting around it. And so that's why when people take it and they take it at appropriate doses, they're really happy to have it. And this is in most cases. I mean, there's obviously, other circumstances where there's vascular disease or there's neurologic problems, or there are other reasons why women have diminished or absent orgasm. But in terms of desire, testosterone, particularly in the perimenopausal and menopausal age group, as that testosterone is, declining, find a lot of benefit across the board. The challenge is obviously there's not an FDA approved product, right? So we're doing this off label. We're having to get things compounded, or we're prescribing male products and having women cut them up. And the guidance there is if they need 1/10 of the dose. We're having to monitor to make sure that the doses are in therapeutic range and not supra therapeutic, right? Because there's a host of problems that can happen in the supra therapeutic range. And then we really need to monitor these women for abnormal bleeding, et cetera. So, I know that Geneve is on the same boat as me, which is like, pellets are quite difficult to deal with in this area because once they're in, they're in. And we've all seen plenty of complications from pellets that you cannot titrate back. So most prescribers who are proficient in this are prescribing a transdermal preparation that can be titrated based on levels and symptoms and report of relief of symptoms. So yeah, I think that my position is testosterone is great for people who need it. It has great results. We need an FDA approved product so that we can do this, all together on the same page and not have to feel like we're skirting the rules somehow because it's not FDA approved.
Exactly. Having a product for women and not having to try to get 1/10 of a male dose would be really great. I think that, overdosage is not trivial and it's very common. I don't know how high a testosterone you've seen in a woman who didn't want to be overdosed. I usually see in the several hundred range, but I've seen as high as 1,200 in a woman. And the side effects of overdosage can be irreversible. I think that's not very well publicized to patients either, that you've got to keep it in the normal physiologic range, which for women, ideally, would you say is what? Where do you want that testosterone level in a female who's a good candidate for that therapy?
Well, it's whatever the lab has as a pre-menopausal level, yes. Right? So whatever they're reporting. And so, to your point, I mean, I've seen probably the highest I've ever seen is in the 900s, but this patient had clitoromegaly. I mean, and
it's permanent.
Permanent. And that is, I mean, as a woman, like that is a significant side effect. And so we have to be so careful. And I think that that's the thing. It's like, yes, testosterone is a good thing. We need it, but we also need to have it regulated so that we can all feel comfortable and confident as prescribers and as patients that, things are going to go in the direction that women need them.
Exactly. I always tell patients too that lab equipment is calibrated to measure male levels. It's not even calibrated to measure female levels, which can be in the single digits to somewhere around 70. But if it's normal for a female level, that lab equipment may report it at a 0 because it's undetectable, because it's just not validated for use in women. But getting a baseline level is important to make sure a woman's not already having a high testosterone for some reason, and then to monitor levels over time. But its greatest utility is to make sure we're not overdosing, which is not all that hard to do. And just another word about supraphysiologic levels. Women who are taking it for muscle mass, athletics, energy, those benefits, if you will, side benefits, come from overdosage. They come as a side effect of a level that's really too high for a woman to safely be sustained.
Yeah. And yeah, there's a whole other sort of wellness slant to this that
Yes,
is
yes.
definitely
Beware
not
the
in this
wellness.
scope. Exactly. And so that, but I think that that is an opportunity for us as physicians to really take the lead and say, okay, there is, or as, licensed professionals to say, okay, there is something here. How do we do this responsibly? Right. It's the same as
Exactly.
a thousand other medicines that many of them can be abused or misused. But also that doesn't mean that they don't have, true value in the role of patient care.
Exactly. Yes, we have to be leaders on this. We had to advocate for our patients, advocate for fellow clinicians, get the word out. Dr. Rebecca Dunsmore-Sue, kudos again for that Green Journal
Yeah.
article. Rebecca's our chief medical officer and leader extraordinaire at Genève. And yes, I highly recommend for all clinicians to read that article. It's excellent. All right, we are getting towards the top of the hour. I want to open it up for any questions. All right. Anybody have any questions about anything we've talked about? I'm not seeing any. I thought there would be a tidal wave, especially about the testosterone. Anything else? All right. Well, I guess we've been very effective at our presentation because everybody's well informed and
I love it. I love it.
yeah,
And
it's great.
I'm sure that everyone here, we were going to talk about pelvic floor physical therapy, but I want to reiterate the role of pelvic floor physical therapists and also sex therapists in this conversation.
Yes.
Pelvic floor physical therapists can be helpful across our patients' lifespans. I think we've gotten into the idea of thinking about them for our postpartum patients, but I think we need to be thinking about them more often for our perimenopausal, menopausal, post-surgical. We think about all the different reasons that I might go see a physical therapist for my back or for my shoulder after surgery. We need to be thinking along the same lines for our patients and their pelvic floor. Anytime there's a problem, honestly, like pelvic floor physical therapy is part of that, whether it's a urinary, incontinence or a pelvic sort of tension issue, whether it's a menopause hormone change from atrophy, or atrophy from hormone change, whether it's vaginismus. Like there's so many reasons to send your patients to pelvic floor physical therapy, and the time that they get to spend with their patients compared to the time we get to spend with ours it'll make you jealous. Like it's like a whole hour. They educate them on their pelvic floor, on the function, on the coordination of the muscles. I mean, it's so, I've been as a patient, and it is really, really cool. And then the other missing component to this, when talking to patients about sexual dysfunction, whether it's during menopause or not, is a sex therapist. Sex therapy, not everyone needs sex therapy. And once again, Lori Mintz shared that 93% of sexual problems can be solved without a sex therapist, meaning most of the issue is just education, just like we were talking about, Lisa, responsive
Absolutely.
desire, just it's not that difficult, but our society has made it really hard. So that's why we as physicians have such an important role to have these conversations with our patients and say, read this book or download this platform, or whatever the next step is.
Get
It
the
doesn't.
Rosie app. Everybody
Yeah, there
get the
you go.
Rosie app.
There's so many. There now thankfully are a handful of options, but sometimes we do need sex therapy, and that could be because of so many reasons. Many that I see are so much shame around experiencing pleasure, around talking about sex. This could be from a cultural reason, it could be from a religious reason, it could be from a trauma reason. That's another thing, though. I don't want anyone to think that people have sexual problems because everyone has had sexual trauma. Unfortunately, a lot of people have had sexual trauma, but a lot of people who have never experienced trauma also have sexual problems. So I don't want to convolute those two topics, but sex therapists are just like regular therapists, except they've been trained in talking to people about these issues. The training we never got, they got. And so it's a wonderful, safe space to learn how to talk about these things, to overcome any roadblocks within the partnership that might be preventing or acting in a destructive way towards progress. Education, removing shame, so many different aspects. So I would encourage you to identify that pelvic floor physical therapist in your community, identify that sex therapist, and that can really be your go-to people to help these patients in a really meaningful way. If you've gone out of your depths, if you want to learn more I highly recommend ISWISH. I got an email that their fall course is sold out, which I don't think has ever happened. So just like the Menopause Society meeting was sold out, now ISWISH is sold out. I feel like all of our dreams are coming true, Lisa. And practitioners are finally going to be educated on these topics. But it's a hopeful moment, I think, where we are in medicine.
It is very hopeful. And I think that for us clinicians to have people like you kind of leading the way and leading the charge for women's sexual health is so gratifying. There's a question in the chat about how much Rosie cost for patients. Tell us about your offerings.
Yes, absolutely. So Rosie is absolutely completely free to download for patients. And something that's actually exciting for me to talk about on this call is that each of you who are interested, obviously, in women's health in some capacity, whether it's psychiatry like Megan or however you're involved, you can actually come on the Rosie platform, apply to be a creator, and then you'll be vetted by our medical advisory board, and then you can actually create content on the Rosie platform.
The quickies. Be a quickie.
Thank you. Yes. And each piece of content is also vetted. So what that allows us to do is have people on for free, and we are sharing evidence-based information from multidisciplinary providers. So that is on the medical side, on the mental health side, on the pelvic floor PT side, and all of that is totally available for free, Luba. There are 3 subscription tiers. One is $10 a month, one is $50 a month, and one is $150 a month. The $10 a month gives your patients access to a library of short story erotica, which can be, filtered towards their taste. They can go from very tame, like The Notebook, to very spicy, not like The Notebook. And also we have specific erotica for patient populations like breast cancer survivors, because through our work, we've learned that breast cancer survivors don't want to hear about nipples and breasts when they're reading erotica, because it triggers them to have thoughts about their breasts and thoughts about their situation. So you can think about erotica. It's highly personalizable on the Rosie platform, but they also get access to their wellness plan, which I could talk about this for an hour, so I won't, Lisa, but it is we create a wellness plan for patients based on how they answer the onboarding. So a woman who's postpartum and experiencing depression and sexual pain is going to get an entirely different experience than a woman who's menopausal and having partner problems and maybe sexual or maybe vaginal dryness. And then $50 includes our group coaching and workshops, and then $150 are access to health coaches, and all of our health coaches are physicians, nurse practitioners, et cetera. So thanks for that question. And I would love for you, anyone who has an NPI, so physicians, nurse practitioners, anybody who has an NPI can come on the Rosie platform, download it, and get the $50 a month access completely for free, because it's very important for me that you all, number one, have access to this information, but number two, feel confident when you're referring your patients. So please, check it out, and we'd be happy to welcome you all as quickie creators as well.
That's so great. Really highly appreciate that. I wanted to just say a word about the erotica, because it is by women for women.
Yeah.
It's completely different from porn, which is usually male focused, and a completely different type of stimulus. So I just wanted to put that out there. The stories are lovely. And as you said, they're categorized. So if you're married and you'd like to read about that versus some other category of patient, it's to your comfort level. So I really appreciate that the library is really curated very beautifully. Really appreciate it.
Yeah.
I wanted to mention one resource for finding sex therapists, and I know there are more than just one, but the American Association of Sexuality Educators, Counselors, and Therapists can be a resource. And nowadays, so much mental health care is being done online, so that's great. Just like Geneve, you can see somebody who's not necessarily in your region. So I think that having resources like that available that patients can access with their partners or by themselves is fantastic.
Absolutely. And, there are so many great resources at ASEC, the organization you mentioned, from sex therapists, but also sex educators. If you want to come in and do a program at your office, there's a lot of different ways to utilize that organization. They have a great conference as well.
Great. All right. Well, I'm inspired. I think I might need to become a fellow of ISWISH.
Yay. Amazing.
Yes. No trouble getting a late career certification. I have time, which is great. So I
love it.
thank you so much, Lindsay, Dr. Harper, for sharing your time with us and all of this experience and expertise. I know everybody enjoyed it. I know that we probably need to have additional sessions where we could just focus on this thing or that thing. We've had a really nice broad overview of female sexual health with a focus on alleviating pain and differentiating different types of desire, helping our patients with various pharmaceuticals or non-pharmaceutical options as they need them. So thank you again. Thanks everybody for attending. These webinars are meant to be shared widely, so please share it with fellow clinicians if you like. Part of our mission again at Geneva is clinician education as well as outreach to patients. So thank you all.
Awesome. Thanks so much, Lisa. You'll have a great day. And thanks to
You
Geneva for
too.
putting this on.
Our pleasure. Thank you. Bye, everybody.